PET-CT is only done when CT findings are equivocal. We're not sure, is this metastatic disease or not? So what is the role of the radiologists? Basically, we need to tell the surgeons, is there only disease confined to the lumen? Is this local mesorectal spread? Or is this distant pelvic spread? And why is this important? Because the surgeon can triage the treatment based on this. And it is also important for the radiologist to tell the surgeon, is there involvement of the CRM? Is there extramural venous invasion? Is it a locally advanced tumor or involvement of the peritoneal reflection? All these are bad prognostic factors. So what does the MR actually do? How does it triage treatment? So you divide the CA rectum into localized disease or locally advanced disease. If it's a localized disease, that means we're talking about T1 and T2 disease, you will go directly for upfront surgery. Then we have a group which is a T3A and T3B. Various societies recommend different treatment for this. But if you go by the American guidelines, they advise the same treatment like the locally advanced. That means you're talking about neoadjuvant prior to surgery. All the tumors which are T3C and beyond, which have MRF involvement, nodal involvement, or EMVI, those are called locally advanced disease. After neoadjuvant, you restage with MR at 4 to 6 weeks. If there is complete response, now there is a new thing coming up of surveillance, but they can also be taken up for surgery. If it's good response, the patients go up for surgery. And if it's bad response, they go for long-term chemoradiation. So this is how MR is going to help the surgeon. The other thing the radiologist tells the surgeons are the planes which are involved. So depending on the planes involved, the surgeon can decide whether it's going to be a LAR, a APR, or a pelvic exentration, or an intersphincteric dissection. So now let's move on how an MR is done. Surgeons always ask us, will you be giving enema? Will you be giving IV contrast? So remember, when we're doing a pre-op MR for staging, you require no enema, no intravenous contrast. There is no endorectal coil needed, but we do give an anti-peristaltic agent on the table to reduce peristalsis. This will help you in making the image quality better. So remember, none of these is required. The only role of intravenous contrast is after neoadjuvant when we were looking for residual tumor. So in a pre-staging, no IV contrast is required. This is more for the radiologists, but I think as surgeons, you must know this. When we are performing an MR, the gold standard, the images sequences we use are the non-fat saturated images. By non-fat saturated, I mean, look at the fat all around, it's all bright. And why we want these non-fat saturated images? Because we want the contrast of the tumor with the fat to show up. If we suppress the fat, you will not be able to see the extension of the tumor. So remember, gold standard are the T2 weighted high resolution images. We take them in all three planes, sagittal, axial, and coronal. The other thing what you must know is wherever the tumor is, once we do a T2 sagittal image, your plane should be exactly orthogonal. That means it should be perpendicular to the tumor and parallel to the tumor to get good images. Now you see the plane of acquisition here is wrong. So the fat plane between the vagina and the rectum is lost. Is my cursor showing? Yeah. So here you can see you're overcalling disease. So what you really need to do, get the plane right. If the plane is right and absolutely perpendicular, you can see the fat plane is clearly seen. So this is very important. We get a lot of images from outside to review, and we see the planes have not been done well. So this is what even a radiologist and a surgeon should also see if the planes have been acquired correctly. So for a radiologist and an endoscopist, the definition of rectum is similar. That means the last 15 centimeters of the GI tract is the rectum, right? Even the anal canal is included in the rectum. So then we divide this into three equal parts, the low, mid, and high rectum. You can see by the white, red, and green line. So what we need to see now is what is the distance of the tumor from the anal verge. This is important for the surgeon to know, and also the craniocaudal extent of the tumor. So like you can see, this tumor is basically more in the upper rectum, and it's even going into the mid rectum. So this information we need to give to the surgeon. So how do you decide which part is the rectum? One is by measurement, I told you, from 0 to 15 centimeter is the anal verge. The other way you can do is look at the sigmoid takeoff. So what do we mean by sigmoid takeoff? So if you look at this video, you can see the rectum is going basically vertically up. The minute it starts taking a horizontal course, that is your sigmoid takeoff, and that is the upper limit of the rectum. The same thing you can see here, this has become horizontal. So we know this is the sigmoid takeoff. It's approximately at the level of the sacral promontory. So this is the upper part of the rectum. On the axial images again, when the rectum becomes into an anterior-posterior direction like this, we know that is the sigmoid takeoff. So this is the upper limit I told you of the rectum. And how do we look at the lower limit? The anal verge. So what you need to see here is the external sphincter. So look at this muscle here, the one which is a circular thick muscle. This is the external sphincter. And what you see inside here is the internal sphincter. So you can take the measurement either from here or from the internal sphincter. You can see the external sphincter comes below the internal sphincter. So if you measure from here, you'll probably give a little higher distance as what the sigmoidoscopy when you do. And if you take it from the internal sphincter, it'll be a little less. But it doesn't matter. Just have a standardized approach. Your surgeon just should know where are you measuring from, and he'll know exactly how to correlate. So whatever you approach, it's the same thing, but just make it a standardized protocol. So the next thing when we are doing an MR, we look at the signal of the tumor. So when you find a dark tumor, like in this first case, we know we're dealing with non-mucin secreting adenocarcinoma. If you have a bright signal like this on a T2 weighted image, these are mucinous tumors. So looking at imaging alone, we can tell you whether this is a mucinous, is it a signet type of mucinous, or is it a non-mucin secreting adenocarcinoma. The other important landmark which the surgeon needs to know is the anorectal junction. They'll always ask you, is the tumor above it, below it? Because that way they can plan what resection they need to do. So how do we identify this? You draw a line along the posterior part of the rectum, posterior wall, another line parallel to the anal canal, and where these intersect, that is the anorectal junction. The other way you can identify the anorectal junction is look at the internal sphincter. This is nice and thick. When this transition takes place into the rectal wall, which becomes thinner, that is the anorectal junction. And this is also approximately the same level where the puborectalis sling is. So if you can identify the puborectalis sling, it's like a sling-like dark structure which goes all around the rectum. So this is where your anorectal junction is. So when you report a tumor, you have to give distance from the anal verge, which part of the rectum it is, what is the craniocaudal extent, and where is it in relation to the anorectal junction. All these should be mentioned in your report. So we've seen the vertical extent. Now let's move on to the lateral extent. How do we study that? So what do you need to see in this? Look at the rectal wall anatomy. We all know it consists of the mucosa, you have the submucosa and the muscularis propria. So if you have bright signal in the lumen, we can identify this dark area, which is the mucosa. But if you have dark signal, which is the air or the fecal matter, we normally cannot see this dark line of the mucosa. We can see the submucosa very well, and we can also see the muscular layer, which is this nice band of dark signal. So this is a dark signal of the muscularis propria that we use to evaluate the lateral extent of the tumor. Whenever there'll be disruption of the dark band, we know the tumor is going to be going into the fat. And the reason I told you we don't do fat suppressed images, we want this dark signal of the tumor to contrast with the mesorectal fat to see how much is the extension. And see, now you see this case, you know there is tumor sitting here. You can see the nice dark signal of the wall posteriorly. Here there is air and we know there's no tumor. But you can see this area here, it is disrupted. So how do we measure the extent? Just draw a line from the expected area where you expect the wall to be and measure this distance. This is called the extramural distance. And this will be discussed in the next lecture, how you'll stage the disease based on this extramural distance. Another very important plane is the mesorectal fascia. Why is this important? Because when you surgeons do a TME, this is the plane of dissection. So we need to tell you, is this involved or not involved? And how do we look at it at MR? It's this pencil line thick black structure you see surrounding the mesorectal fat. This is the rectal lumen. The mesorectal fat will have these lymph nodes, vessels, and nerves, and you have the mesorectal fascia all around. So what you need to remember now is in the upper rectum, the peritoneum will reflect along the anterior wall. So that is the peritonealized part of the rectum. So the anterior most part in red is the peritoneum. And on laterally and posteriorly, you'll find the mesorectal fascia. In the mid-rectum, the peritonealized part is much lesser and most of it is the mesorectal fascia. And as you come to the lower one-third, all of it is the mesorectal fascia. Why this is important? Because if you are saying involvement anteriorly, that is peritoneal involvement, you're going to upgrade it into a 4A, whereas CRM involvement is different. How do we look at the peritoneal reflection? So if you look at a female patient where the uterus and cervix meet, this dark structure which you see, it will go from this area, from the posterior part of the cervix up to the anterior wall of the rectum. So this is the peritoneal reflection. When you are reporting, you need to tell the surgeon, is the tumor above or below the peritoneal reflection? And what is the importance of this? Because if it's above, you know this is not a rectal tumor, it is a sigmoid and the treatment is different. In females, what you find is this structure from the tip of the seminal vesicles, again this black line, which will go and insert at the anterior part of the rectum. On the axial images, this is also beautifully seen. It is this Y-shaped structure, which is going and attaching to the anterior part of the rectum. And this is basically akin to the wings of a bird. And that is what they say, this is what is called the peritoneal reflection, okay? Then most surgeons come and ask us when they're discussing, oh, show us the presacral fascia, show us the denonvillous fascia. We as radiologists cannot differentiate between the CRM and these fascia. So they are normally, unless it's a nice fatty patient, you'll have a lot of fat in between. I'll just show you a case, then we can differentiate. But most times we cannot tell you the difference between the presacral fascia as well as the CRM or the denonvillous fascia, which is just a fascia below the level of the peritoneal reflection in the pouch of Douglas. I've already told you this earlier, but I want to re-emphasize this point. If there is involvement of the peritoneal reflection, it is a 4A tumor. This is CRM free, but peritoneal reflection involvement. So this is a stage 4A. So don't go wrong in reporting the anterior part in the upper rectum or in the mid rectum. Be careful. Do not call it CRM positive. The anterior part is involved. That is peritoneal reflection involvement. And when do we say that there is involvement of the CRM? CRM is akin to the fascia. This is your plane of excision. So if it is less than 1 mm, we call invasion of the CRM. If it is less than 2 mm, we call it threatened. So that is how we tell you whether the CRM is involved or not involved. Next, moving to the sphincter anatomy. This is very important because the surgeons want us to know, is the sphincter complex involved? Is the intersphincteric plane involved? So you should know the anatomy of this. These are the two levator ani muscles. This is the coronal image. And here you can see this is the ischiococcygous component. This will go and insert into the puborectalis muscle. And below that, we have the external sphincter. These are the three bundles of the external sphincter, the subcutaneous, superficial, and deep. And these bundles are separated by this fat. This is how we identify this. And the internal sphincter is the part inside. Surgeons also ask us, tell us the relation to the dentate line. As radiologists, we cannot see the dentate line on MRI. But what you need to know that we can give a approximate level where the dentate line is. And this is the fat plane between the deep and the superficial component of the external sphincter. So if you draw a line here, this is approximately the dentate line. The importance of this is anything below this are normally squamous, anything above is adenocarcinomas. But this is not the role of the radiologist to tell you is this a adeno or a squamous. This is the role of the pathologist. All the radiologist will do is stage the disease for you. And another muscle which is very important is the conjoint longitudinal muscle. So muscle is basically a continuation of the longitudinal muscle of the rectum. The internal sphincter is a continuation of the circular muscle of the rectum. And the importance of this lies is that the intersphincteric plane is lateral to this. Lots of time people think that this is the external sphincter and they will overcall intersphincteric involvement. So the fat which is between the CLM and the external sphincter is the intersphincteric plane. This is very important because this staging for low rectal cancers is different from the upper and mid rectal cancers. You don't need to really remember this. All is required from a radiologist to tell the surgeon which plane is getting involved in case they want to do a intersphincteric resection. Another important thing, which is a very bad prognostic factor, is extramural venous invasion. What do we mean by this? If the tumor extends into the venous drainage of the rectum, it can be small, medium, or large size vessels. And how we identify this is look at the signal of the tumor. The signal within the vein will be similar. So if you have any structure which is tubular or elongated and having similar signal, this is what we call as EMVI, and this is a bad prognostic factor. Next is the nodal staging. So in nodal staging, what you need to remember, all the nodes from the inferior mesenteric group right up to the pelvic, except the external iliac group. These are all loco-regional spread. External iliac is metastatic spread. If you have involvement of the inguinal glands, these are basically, if it's a low rectal tumor, this is loco-regional. If it's an upper rectal tumor, these are metastatic. MR is not a very good modality for telling you nodal spread. However, after many years of research, they've come up with a certain criteria. When do we call these nodes involved? So we use the size criteria. In this, if a node is more than 9 mm in the short axis, we will consider it involved irrespective of what signal, what margin. So 9 mm is definitely involved. If you have a node which is between 5 and 8 mm, we need to look at the morphology of the node. By morphology, what do we mean? It's losing its normal reniform shape. It's becoming round in shape. It's having irregular margins and it is showing heterogeneous signal. So these are the three criteria. So if a node is less than 5 mm, you look at all these three criteria. If all of these are met in a less than 5 mm node, we call this involved. In a 5 to 8 mm node, you can meet only true criteria to call it involved. So I hope this is clear because what happens, lots of people, radiologists look at diffusion. If they restrict on diffusion, that does not mean involvement. Even reactive nodes will restrict. So you have to look at the size and the morphology and then decide, is this involved or not? So just let's look at the example. This is a less than 5 mm node here. It's become round. Margins are plus minus irregular. The signal is definitely not heterogeneous. So it has not met all the three criteria. So we cannot call this involved. On the other hand, this node is between 5 and 8 mm. It's become round. You can see the heterogeneous signal. So we will call it involved even though only two criteria are being met. And this is unequivocal. These are more than 9 mm. So these are only size criteria. And we call these involved. Another entity is extranodal tumor deposit. So if you have deposits like this, which are away from the main tumor, the index tumor, and not confining to a nodal configuration, we call these deposits. And this will upstage your disease to N1C. So now I think we've discussed. I just want to show you a video and let's see if you all can see everything now what we've discussed. So when we're looking at a T2 weighted image, what are we looking at? At the craniocaudal extent of the tumor. Okay. So first we have to decide, is this in the mid-rectum, high or low? So we know this is our anal word. You can take the circular muscle here. Okay. Okay. So now from here, we start measuring. Remember, you go in straight lines, one line here, one line here. It's very close to the sigmoid. Sigmoid is the horizontal part. So this is a what tumor? Excellent. So this is the upper rectal tumor. We measure the lower edge of the tumor and tell the vertical extent to the surgeon. Then we look at the peritoneal reflection. So where did I tell you the peritoneal reflection is? Sorry. So peritoneal reflection is from the tip of the seminal vesicle. This is seminal vesicle. This is where it's going. So anything below this is the tumor. So the tumor is below the peritoneal reflection. Next thing, we look at the anorectal junction. So the tumor is above the anorectal junction. So this is what we look at in our sagittal images. You can look at the area of dissection for the surgeon, the presacral space. You can see this is totally free. We do have a few nodes which you can see in the presacral area that we will evaluate the size and decide accordingly. Look at the adjoining organs. You can see the bladder, the prostate, the seminal vesicles. They are all free. So this is what we are looking at on our sagittal. So this is what we are done with the sagittal. Then we move to our axial images. What do we see in our axial images? The lateral extent of the tumor. Okay. So we'll come to the level of the tumor. The signal of the tumor is dark. So we know this is a non-mucin secreting. Look at the hypointense signal of the wall, very well seen on the left side. It is not seen on the right. It's plus minus had the tumor gone out. So if it's either a T2 or a T3A, we've seen that. Then we evaluate the nodes. The nodes don't look involved. They're all not meeting the criteria. We look at the mesorectal fascia. You can see it beautifully. This black line all around. We know that is totally free. There is no extramural venous invasion. There's no tumor going to any of the veins. So we know this is either a T2/T3A, N0, no nodes. CRM is free. EMYR negative. Okay. And we look at the coronal images next. In the coronal images, we'll evaluate the sphincter. Here, because it's the upper rectal, there is no role, but I just want to show it to you how you look at it. You're seeing the levator ani beautifully, absolutely clear. You can see the puborectalis sling, the deep component, the subcutaneous and superficial component very well. Internal sphincter looks beautiful. The CLM is fine. The internal sphincter, the intersphincteric space is fine. So this is how you're looking at only 3 gold standard images. We're doing non-fat saturated T2 weighted small field of view, high resolution images. And just these 3 images are adequate for you to come to your final stage. Thank you very much. And with this, I'll hand over. I take off.
होल्ड करना होल्ड ठीक
So we can see direct spread, like I told you, this is in peritoneal reflection anteriorly. Even metastatic disease in the peritoneum is very well seen on MR, though we prefer to do contrast. So diffusion and contrast will show us excellent metastatic disease. Earlier, people had this concept, this has only been seen on CT. We can see it on MR also very well. Even on a plain scan, contrast just helps you to be more confident of telling you, especially they're very small deposits. Contrast helps in that. Otherwise, if you can see them on diffusion beautifully, on even your plain scans beautifully.
MRI reading and interpretation of MRI and the clarity of images.
So this is all 3T images, but 1.5 also gives you excellent images. It's what the recommendation is 1.5 or above. Any strength machine is good. Both are excellent. Of course, 3T has the advantage of a little higher resolution, but there's adequate information even on a 1.5.
The low rectal cancer, sphincter involvement, does it change the stage of the disease or just we interpret as sphincter involvement?
See, like I told you, the lower, I think
Yeah.
cover it right now. We state it differently because your management will be different. What we used to call as T2 in the upper and mid, that is confined to the wall. But here, when there's sphincter, internal sphincter involvement, it goes into a T3. So he'll cover this right now. I was just showing the normal, we'll cover the pathology.
So, good morning, everyone. Very great presentation by Dr. Seema Sood ma'am. And I am myself Dr. Narottam Kadaria. I am working as a senior consultant in radiology department of BLK Max Hospital. So today my topic is MRI of rectal cancer with tumor staging and imaging. As you all know, MRI is a game changer for treatment and prognosis of patient with CA rectum. And the major advancement in the treatment of CA rectum, that is TME, that is total mesorectal excision, and neoadjuvant treatment, mostly radiotherapy with or without chemotherapy, significantly change the prognosis of the patient with CA rectum. But for that, we need accurate local staging so that we can plan the treatment process in advance. So MRI is the most powerful tool for the local staging. And to tell you the staging of the tumor at the primary stage, if we can directly go for the TME or we will need any neoadjuvant therapy. So I will start with the protocol. So in protocol, most important sequence, as ma'am has described previously, is T2W images without fat saturation. And we need small FOV so that there is significant increase in the soft tissue resolution of the images. First, we start with the sagittal images to plan our study. And according to sagittal images, we take axial and coronal images perpendicular to the axis of the tumor. And then DWI images are not that helpful for the primary staging. It's more important in the restaging, where it can accurately tell us if the tumor is present or absent, or is everything is fibrosis. We can use osmolytic agents to decrease the peristalsis, more so in the upper rectum, whereas peristalsis is more. Endorectal coil we don't use because it causes distension of the rectal lumen and can upstage the tumor by decreasing the mesorectal fat. So, as ma'am has said previously also, the axial plane should be perpendicular to the long axis of tumor. Otherwise, it will upstage the tumor. Like in this case, these red lines are two axial planes, and there is loss of fat planes between the prostate anteriorly and the rectal mass, and it will upstage the disease to T4B. Whereas that two axial planes perpendicular to the tumor, there is clear fat plane between the prostate and the rectum, and decreases the staging to T2 stage. I will show you a few slides of the normal anatomy as discussed in detail by ma'am. So the layers of the rectal wall, you all know there are three layers. Innermost is this black line is the mucosa. Then outer to that is submucosa, and this black line is the muscle layer, which are multiple layers. Sometimes you can see fat between two muscle layers, but normally in MRI we only see two layers. One is muscle layer, and we normally can't differentiate between mucosa and submucosa. And this red line is the mesorectal fascia. So this is the same slide showing this line is the mucosa, then white one is the submucosa, and black one is the muscle layer, muscularis propria. So this is the schematic diagram of the mesorectal fascia, where the mesorectal fascia is attached. Mesorectal fascia is thin fibrous strands which surrounds the rectum. And in case of CA rectum, the most common surgery is TME, in which we took out all of the mesorectal fascia along with its contents. So the mesorectal fascia posteriorly it merges with the presacral fascia. In the upper and mid rectum, it is deficient anteriorly, where the rectum is covered by the peritoneum, but lower part of the rectum is completely covered by the mesorectal fascia. So these are the axial and coronal and sagittal images to show you the mesorectal fascia. You can see this hypointense. Whenever I see hypointense, it means black, and hyperintense in white in radiology. So these black hypointense lines, most of the fibrosis or fibrous strands or tendons are like black or hypointense on T2W images, and the pathology is mostly hyperintense on bright on T2W images. So these thin hypointense fibrous strands are the mesorectal fascia. So anteriorly, it is in the lower rectum and the mid rectum. Most of the part is covered by the mesorectal fascia. These are the coronal images, and these are the sagittal images. You can see posteriorly the blue arrows, and mesorectal fascia merges with the presacral fascia. Then peritoneal reflections. These are the schematic diagram to show you the peritoneum, how the peritoneum covers the rectum. So peritoneum covers the anterior part of the rectum, more so in the upper rectum than the mid rectum. And where the peritoneum turns back, this is the peritoneal reflection. So these are the axial images of the lower rectum, mid rectum, and the upper rectum. In the high rectum, peritoneum is more covering the rectum, and lower rectum, there is no peritoneal covering. These are the MRI images of the peritoneal reflection. This is the anterior, like already ma'am said, this is seagull sign, bird, like in the bird. This is the posteriorly, this is the peritoneal reflection where it turns back anteriorly. And this is the superior part of the peritoneum, thin hypointense lines. So reporting template, which is universally used, it includes all of these points, which I will describe in the details, all the points. So this includes clinical details, comparison if any previous scan is present, findings, that is includes tumor location, tumor morphology, mucin component if any, T category of the disease, mesorectal lymph nodes, extra mesorectal lymph nodes, EMVI, CRM, and adjacent organs of the pelvis. So clinical details, clinical examination is very important. Where is the, on the rectal examination, where is the mass is the present, endoscopy report, if what is the grading of the tumor, histopathological reports, previous scans if any, for the comparison, and if patient has taken any previous